let's get started. And welcome to this session on the exciting topic of total body PET and its opportunities and challenges. My name is Mark Lubbering, and the other chair is Paul Marsden. Bruce Rosen, who is in the program book, unfortunately couldn't join us. And I think we will start immediately with Professor Terry Jones from UC Davis nowadays, who will give us his opinions on the opportunities for mapping the body's peripheral neuroreceptors.
Good morning. At the first meeting of the Society of Neuroimaging Mapping in Aarhus 21 years ago, organized by Albert and Tony, I showed this new scanner. First of its type, it was extended the axial length of the camera to 24 centimeters. We discarded the use of scepter, highly sensitive, and of course, be able to look at the whole of the brain, which is very important, the sensitivity of the top of the brain, and perhaps more important, to look at the cerebellum, which people were then developing as a reference tissue, and up until then, it's been relatively insensitively looked at. So it's very successful, and since that time, most scanners are about 24 centimeters now, including the HRT. The detectors have changed. That was the BGO system. Now it's LSO, and you've got time of flight, and you've got MR and CT. But the basic geometry of the system is still that. And I've been reflecting, said, why did we stop extending at that point? Because we believe that half the neuroreceptors, or half the neurons in the body, are actually outside of the brain. So there's lots of neuroreceptors to image outside of the brain. And why didn't we, go a bit further and actually build a proper scanner which looks at all the body and all the neuroreceptors which are available? Well, the good news is one has been built, and it was finally constructed by a company in Shanghai called United Imaging Healthcare, and it also contains 24 centimeter panels, but 8 of them, bolted together, bringing together a total of just over half a ton of detector. So it's pretty sensitive. So what was the stimulation now to build this camera? Well, as you know, most PET studies now are total body, of course, and that requires scanning the patient through and requires using a tracer, which is fairly stable at any given point for obvious reasons. So at this point in time, scanners are only picking up about 1% of all the photons coming out of the body, which is rather limiting. And really, when you consider in some research environments where they've got a cyclotron working, investing in chemistry and GMP and scanning facilities and radiation dose to the patient, and you're only recording 1% of the scan, of the data, it's pathetic, really. And you think of that wonderful, you're missing all that data. And of course, the answer is to surround the patient with a detector and pick it all up. Given that, there was a consortium put together, driven by University of Davis in California, Simon Cherry and Ramti Badawi, together with the folks in Berkeley and Philadelphia, and lots of advisors from industry and academia supporting it. And they got some money from the NIH to simulate what would be the gain if you actually had one of these cameras. Well, they worked it out that you get 40 times more signal, which is a lot of signal compared to now. And for any given region of the body, you get 4 or 5 times. That's quite a lot. And then we looked at signal noise. You can reconstruct at higher resolution, detect smaller lesions, lower grade disease, better statistics. And you can see, for example, in this simulation, how things come into more relief by virtue of getting better statistics, really. I mean, that's as simple as that. Also, of course, beautifully, you can get the kinetics from the whole body simultaneously. I don't need to tell this audience of the impact that's going to have. And particularly, you can pick up good image-derived input functions from the arterial blood, out again, to be able to do all the magical compartment analysis all you people know so well. You can do it perhaps more systematically, bearing in mind metabolites, again, from picking up the arterial blood in an efficient manner. Well, of course, you can, because of the sensitivity, compared to conventional PET, you can scan for much longer, an extra 5 half-lives. So with carbon, you can go for 3 hours, and fluorine, 18 hours. And zirconium, which you know is used for cells and antibodies for up to a week, for weeks and months. So that's really quite important. And particularly when you think you've got perhaps low affinities binding agents, or you want the background to clear, non-specific longer, have more time. So imaging later is quite an advantage, we understand. Or alternatively, you can give a factor of 40 times less dose if you want to keep the same quality of imaging now, and which is quite important if you want to repeat studies or maybe study people or younger people to minimize the radiation dose exposure. But this was the problem. But I mean, even to build a system at the university, a university-built system, which Simon and Ramsey were posing, you need $15 million. But as you all know, to get money from a grant, you need to have some prior information, some data to show people, and that was a bit of a problem, really, because we didn't have this, the total body stuff. And we had a few failures. But anyway, Simon and Ramsey, they went eventually to the NIH, and there was a director's call, called a Transformation Research Award, and they got it. They got $15 million. As a result of that, this company in Shanghai said, look, we'll build this camera, and we'll build it in 2 or 3 years, and what's more, we are committed to it being a commercial product. Now, that was very important, because we felt this, we didn't want to have a machine that's stuck in one university, and that was it. We thought it was important to get a number of these machines out there, certainly in the first instance in the research community, because it needed a lot of input, a lot of exploratory work to really exploit it, and that was quite important. So we really were, we said that there must be a God up there after all, coming out and commit themselves to producing a clinically commercial machine was quite a windfall for us. And what they were doing, they had a standard camera, or a high quality machine, and they were simply going to bolt 8 of those together. And there's a slight complication of putting it all together and connecting it up and things. As you can imagine, that's not trivial. Eventually it was built, and Simon and myself and Ramsey were celebrating it in May. This is the drain pipe, which is full of radioactivity, which is going to look at the uniformity across the whole thing. So you can imagine the challenge of being able to characterize this machine in this way. There's Ramsey here, and I'm just checking it's not getting too hot, because we were always worried about the electronics being quite a lot of heat coming out of this, and it seemed okay to me. This is a uniformity scan. Things to be improved here, but this is the very early stages. And even you can pick up low activity as shown here in this time. And nice little study where they've injected through a catheter through United Imaging Healthcare. You can see that across 2 meters, you see the kinetics, which it gives you a flavor of what you're going to be able to do in a human being, this degree of temporal and spatial resolution. The sensitivity across the system is like this. It peaks over a meter or so, and it then falls off on this jagged edges because the way they take the data at the moment in this form. So we just look at the 100 times 10 to the 9 LORs, just gives you some idea of the data set which this machine is producing. The resolution looks good. 2.4 you're picking up, maybe 2, so that looks good. And of course, typical hotspot phantoms, again, are looking encouraging. So what is this machine going to be used for? I think there's 2 main areas. We'll be able to do what we're doing now, but much better. And then there's going to be a paradigm shift. Now, when I say much better, for example, you'll get better image quality, or you'll get a lower dose. You'll be able to pick up the arterial blood much more efficiently. You'll be able, therefore, maybe quantification will be more encouraged. You'll get better statistics for your kinetic analysis, even begin to pull out the micro K1, K2, K3, K4, rather than just lumping into binding potential or volume of distribution. There must be information there. And also, because it's quite expensive getting new tracers with cyclotron, because of the 5 half-lives, you'll be able to transport ligands over a much bigger distance. So people will be able to access from commercial centers, for example, much further away than now, and that will begin to enhance their own local repertoire of studies without having to invest heavily in GMP and cyclotrons and all that sort of stuff. So these are the things which are really going to impact doing what we're doing now, but better. But the big step, of course, is that taking the whole body simultaneously. That's the paradigm shift, which we cannot do now. And given those opportunities, these are sort of summary of the research procedures which we foresee. For example, detecting very low occult disease like micrometastases and plaques and inflammation and infection, total body kinetic for drugs, labeling a drug and seeing the total body kinetics is unique. And of course, you can look at pharmacodynamics as well. A good way of testing potentially new ligands in humans directly by the small amounts you need to look at whether they are distributing themselves as they should be in the human, translation for biomarkers, and of course toxicology. If we're interested in knowing whether some particular compound is concentrating somewhere, this is the way to do it. Distribution of tissue blood flow is quite important. And then, of course, the low-dose studies, repeat studies in the same subject, multiple tracers, normal subjects, young people, and even the fetus, as we were encouraged yesterday. But the really exciting thing is this brain-body. And all the aspects of looking at anxiety and Alzheimer's disease and all these other diseases are possibly now going to be looked at because of the body interaction. Now, this brain-body thing isn't new. This is Henry Maudsley. He was a famous psychiatrist in the Victorian England, and he set up a psychiatric hospital, actually, which is now embodied into this university, King's, and has a very famous Institute of Psychiatry to go with it. So he was very impacting, but he gave a series of lectures in Victorian England where he was showing his observation between physical manifestations and psychiatric manifestations, such as in pregnancy and puberty and some gastric problems or cardiac problems. So this brain-body thing isn't new. He was actually documenting it quite extensively. So, and there's now, I understand, quite a move to integrate mental and physical health. And it seems, of course, as far as PET is concerned, the real development in terms of ligands and methodology has been in the brain. That's where the real technology and methods are driven and experienced. And I've got 70 validated traces. I'm sure there are much more than that, covering all these areas of brain function. And can we translate that skill base, which this room represents, to the body? And especially when you've got half the neurons sitting in the body waiting to be imaged. Maybe one low-hanging fruit is just to look at water activation. Now, we made a lot of nature papers and science papers when we started to do brain activation before the fMRI boys came in, but that was very successful because you saw the whole system. Now we can see the whole body. And it's interesting to begin to think of paradigms where you're stimulating areas, or areas are stimulated where they interact with simple activation studies. MRI boys can't come near that. There isn't a total body MRI, and the bold, I think, doesn't work in the body. So there's a lot to do there in the first instance, just by interesting paradigms of how the two regions may interact. But of course, this is the one which is really exciting, the wiring of the body, and the fact that you've got neurons and neurotransmitters either side. And a simple example, this example was serotonin, where there's said to be the bidirectional communication and terminals on both sides. You begin to think, if you're a neuroimaging, neuroreceptor imaging society, this must be an important area to look at. So, neurotransmitters, you guys, for translating. Well, one example could be dopamine, looking there, and we have ligands for that, and for dopamine and serotonin. And I just explore that why the Explorer now is still undergoing physical testing and will be going to America at the end of the year. We hope to do some clinical work in Shanghai before it's moved, with FDG, for example. But it won't be until next year we get some work coming out of Davis. But in the meantime, there's the family of Explorers. One was a Mini Explorer 1, which we built with components from Siemens, And then United Imaging has also built one using their technology. So Simon and the folks in Davis are beginning to use this now. For example, it's an injection of FDG. You can see the temporal resolution, and it's going out, but it can go for 18 hours. So clearly, FDG has a K4, because there's not much left in the brain or the heart. So you can show the power of being able to really follow such traces over extensive time. And here is a raclopride study, which is done. It's the only receptor study that they've done so far. You can see the quality. It gives you some idea of what you're going to be able to see in human beings when the system gets working. The time activity curves are shown here. Yes, you can see the striatum beautifully coming up, but you can see where the rest of the stuff's going, which is a lot is going into the liver, as you can see here, and indeed the gut is gradually increasing over time, which presumably is driven by metabolites. So that's a bit of a challenge, and there's a Logan plot here. So this is challenging. This is very challenging. My good friend Rich reminded me that the density of receptors out here is much less than in the brain. So we are being challenged with that signal, which is fine. And of course, liver metabolites that I've just shown you. But yesterday, there were two really nice presentations on the COX inhibitor and the synapse work, which show beautiful total body stuff with these receptors, which weren't being interfered too much, as I could see it, with metabolites. So, you know, there will be systems there which are not too dominant. And I remember in the 1980s being told by some very famous pharmacologists, don't bother to image receptors. They'll be swamped by non-specific. And now you've got 300 people committed to neuroreceptor imaging. So, you know, you've got to move on. And so that's a challenge. And maybe we think about developing ligands, which is less metabolism associated with them, which hasn't been an issue so far because the blood-brain barrier has kept a lot of them out. And of course, the whole non-specific binding may be different from what we've been used to in the body. So for consideration, what are the interesting normal physiology questions, neurology and psychiatric, which we can ask of this? And David Brooks is going to give a talk on what he thinks the application in neurology will give, and Phil Cowan will talk about the psychiatric questions. Which are the receptors have we already got? Can we repurpose? We can use now for this. And what traces you've already got in your bottom drawers, which didn't work for the brain, maybe. Some of those are going to work for the body better. What are the opportunities and challenges? Well, we've seen the challenges. And maybe biomarker development, as I said earlier, will take an extra focus of minimizing peripheral metabolism. Thank you very much.
Thanks very much, Terry. We'll save any discussion to later because we've got three provocateurs to get the discussion going. So firstly, we'll have a bit more background and some ideas from David Brooks, who's currently at Newcastle and Aarhus. And he's going to talk about opportunities and challenges in CNS and peripheral nervous system. Thank you.
I hope you can hear me. Thanks very much. It did occur to me, though, Terry, that while your 2-meter-long PET machine would be fine for our Chinese colleagues, when we get to American basketball players, you may have the feet sticking out one end and the brain sticking out the other end, and get a very interesting abdominal scan. So you may have to add another ring or two onto your, stick another $500,000 or so onto the price. Okay, so essentially, Terry has already run through a general set of advantages of being able to use whole body PET scanning, but I want to break it down into where we might be helped in the neurosciences. And the first thing is, although The crystals aren't any smaller, as I understand it, because of the huge increase in sensitivity that's provided by collecting radiation from the whole body. In principle, one should get much higher resolution and sensitive images. This means we can start to look at sub-areas. So in the cortex, we can start to take cortical layers apart. Brainstem nuclei, we should be able to see better. Individual subunits of the thalamus. Nobody still really can identify well the peduncular-pontine nucleus, but with cholinergic or glutamatergic ligands in this machine, it may now become possible. Pediatric neurology, well, there are lots of kids who have epilepsy due to dysplasias or tumors. Again, we're always very reticent to put children into PET scanners, but you can bring the dose down 6 to 10-fold with this machine, and it now becomes a realistic possibility. There's been very little neurology work done with PET on peripheral muscle metabolism because it's generally very low, but in fact with a high sensitivity system you should be able to pick up changes in different muscular disorders. I'll come on to that. Similarly with the spinal cord has very low metabolism, but it's not so low that one can't pick it up, especially in the presence of pathology. And then perhaps most interestingly, where you have conditions where you're looking both at systemic problems along with brain problems, you might want to look at what happens after stenting coronary arteries to brain function. It's known that you get a loss of brain function cognitively and metabolically after these operations. We know that in Parkinson's, multisystem atrophy and other degenerative diseases that systemic organs are involved. The connective tissue disorders like systemic lupus erythematosus can affect the brain and the joints. And finally, of course, if you get a brain tumor, it's often a metastasis, and it helps if you can do a quick scan. And this probably is going to be the biggest use in clinical practice. Looking at the whole body quickly, you can put 20, 30 patients through in theory with snapshots if you have a whole PET machine, whereas at the moment you have to do rectilinear scans or multiple scans to see where the metastases originated. So, just to give you a diagram of the cortex, I'm sure you all know this, but the cortex has 6 primary layers. Some are output layers like layer 4, others like 1 and 6 are input layers, and then you have interneuron layers 2 and 3. In principle, we want a machine that will start separating the function of these different layers and looking at the way they integrate. 7 Tesla MRI is starting to begin to do this already. If we get a high enough resolution PET machine, there's no reason why we shouldn't do the same, both with FDG and receptor mapping with this new wonderful synaptic agent that Rich has invented for us all. Then again, we could start looking at cortical layer synaptic structure with one of these high-resolution machines. The cerebellum, again, we just tend to get a whole cerebellum image, cortex and white matter and the central nuclei, but all the brainstem connections should now be revealed. We should be able to pull out the brainstem nuclei individually instead of just seeing a composite midbrain or pontine signal. And as an example of this, this was an F-Dopa PET scan, which we did, I don't know, at least 10 years ago, using one of our older PET CT cameras. And you can see, even with this old machine, putamen, head of caudate, but you can see there is also pallidal signal, though we can't really differentiate the internal and external pallidum. You can see that the tegmentum and raphe and locus ceruleus can all be discriminated with this tracer. But with a machine of the sort that Terry is wanting to devise and provide, you could start to see these nuclei far more clearly without problems with wash-in and wash-out signals. And we could start to get a handle on the neurogenergic system, the serotonergic system, and the dopaminergic system, and PPN as well. If we had cholinergic tracers, we could look at that and define it accurately in the brainstem if people want to put DBS electrodes in and treat Parkinson's patients for gait disorders. Peripheral muscle disorders. Well, there are a whole range of mitochondrial disorders, and MELAS in particular affects both muscle metabolism and brain metabolism, but there's been relatively little PET work done in these disorders because it was assumed that the muscle signal really wasn't that easy to discern. But again, with one of these high-resolution cameras, that now becomes possible. We can also look at metabolic dystrophies, inflammatory disorders, toxic disorders of the muscles, polymyositis as a complication of cancers like lung cancer. And just to show some examples, this is obviously with an old conventional scanner, dermatomyositis showing increased metabolic activity with FDG in the shoulder muscles here and in pelvic muscles. But you'd see all that in one shot if you had the whole body PET machine. Interestingly, if you get cancer, muscles actually have a non-specific increase in their metabolism for reasons that are not entirely clear, but this patient with a squamous lung cancer is showing increased muscular activity, metabolism in the intercostals and the diaphragm. And these are sorts of things that one can investigate the cause of this. It's still a little unclear why tumours trigger this reaction. Spinal cord, this is an astrocytoma, which is easy, even with conventional machines, to image. If you have neurosarcoidosis, however, much more difficult. It's very patchy. Some is active, some is not, but you can pick up active areas of neurosarcoidosis right through the whole spine and the brain at the same time if you had access to a whole body scanner with high sensitivity. In ALS, interestingly, spinal metabolism, it seems to be increased. I was expecting that it would be decreased, but reports now are showing that as you lose brain metabolism, as motor neurons die off in the brain, there seems to be some form of reaction along the length of the spine where interneurons become more active metabolically. And again, this would be a very interesting example to use synaptic markers, the SV2A tracers. And again, with a whole brain machine, clearly one could see all this in its entirety without having to do separate shots of spine and brain. So if one wants to include brain and the whole body together, an obvious example is connective tissue disorders, and this is systemic lupus erythematosus, which leads to cognitive dysfunction, psychoses, severe depression. You can see there's a general decrease in brain metabolism, which improves if you treat with steroids and cytotoxics. The patients recover, brain metabolism recover. But you can also see that the disease involves widespread joints, knees here particularly, so that one can pick up all this up and get a holistic view of what's going on in your subject and see whether your drug regimen is actually working with one shot. This is an experiment. This is not pictures from Newcastle, but in Newcastle we have a major program running on stenting elderly patients up to the age of 80 who have non-ST elevated cardiac attacks. They usually have a blockage in one of their main arteries. They can be stented, and 80-year-olds tolerate this very well. But unfortunately, there is also often a loss of a few IQ points after these procedures. And with this kind of whole body machine, one could look and see what the effects of stenting on whole brain FDG are. And at the same time, one gets a picture of the cardiac function and how stenting has also improved or not cardiac function. This is work that Per Bohammer in Aarhus and I have been involved in, looking at systemic dysfunction in Parkinson's disease. As you may know, there is now a school of thought that Parkinson's disease may not start in the substantia nigra at all, but may actually start in the olfactory bulbs or in the bowel due to ingesting some toxin. And here you see Bo has taken 11C donepezil, which I've labeled it as an acetylcholinesterase marker. Someone will tell me it's a sigma-1 receptor marker. And if you take 11C donepezil, you can see there is a loss of the cholinesterase signal in the small intestine in patients who have REM sleep behavior disorder, which is a prodromal form of Parkinson's disease, and Parkinson's disease itself. If you look at MIBG scans with SPECT, you can see there's a loss of the sympathetic innervation of the heart. Now, in practice, there are tracers which will look at all this together. So With fluorodopa, you could look at the basal ganglia, the striatum, and the cardiac signal all in one go, in principle. You can look at cholinergic function in the brain and in the intestines all in one go again, in principle. So a lot of these combined brain systemic problems can be looked at holistically in conditions like degenerative disease, Parkinson's, and multisystem atrophy. Pediatrics, well, pediatric vasculitis, one example is Takayasu's disease, where the large arteries are affected. You can see here there's inflammation in both the femoral arteries, and some hint of inflammation up in the aorta here that a whole body scan would pick up very nicely. But mostly, of course, children are either scanned because they have a cancer or because they're having seizures. And again, this is a very nice way of showing cortical dysplasia. Here you see a hint of cortical dysplasia in the right here. And you can see that there is a hypermetabolic area, which shows up very nicely on the pediatric scan. And with these very low doses, it's not an issue to take children from the age of 5 or 10 and do these types of scans. You don't have to worry unduly about the level of radiation they may receive. So I'm going to finish there, and I guess I've repeated quite a bit of what Terry said, but with whole body PET, in principle, you should have far better image quality. You can either reduce the radiation dose or the scanning time, push more patients through clinically if you wish to do that, and you get a holistic view of this pathological dysfunction. For neurology, it now opens up the spine and muscles for imaging. We can see, hopefully, better what's going on in the brainstem and basal ganglia, possibly cortical layers. You can find the origin of metastases in one scan, and perhaps the biggest door that's opened is that it becomes much safer to do pediatric imaging. Thanks very much.
Thank you, David. And the next speaker is Professor Philip Cowan, who will be giving his view on the use of the total body PET in psychiatry.
Well, thanks for the invitation to speak to you today. I work on the psychopharmacology of depression, and I expect you can tell from my appearance that I've been doing that for quite a long time. In fact, I was trained in psychiatry at King's College Hospital, and in those days the department was fairly psychoanalytic in orientation, so we didn't talk about the brain much when we were at work. But even though with the advent of scientific medicine over 2,000 years ago, it's been clear that the brain mediates thinking and feeling. With the advent of biological psychiatry, we started to think about mood disorders as being brain conditions. But in fact, more recently, again, it's become clear that we are embodied creatures, and people with depression, for example, certainly have changes in their bodies and experience their bodies differently. I thought for the purpose of this talk, I would focus on one aspect of this, because there is more interest now in how changes in the body might be important in the causation of depression. And I'm going to talk about one particular idea, which is that inflammation might play a role in pathophysiology. And I've just listed here 4 points why people think that inflammation, both in the periphery and centrally, might play a role in the causation of depression. Firstly, if you have bad flu, you have some symptoms that resemble those of major depression, particularly anhedonia, sleep disturbance, and fatigue. Secondly, if you carry out blood tests in patients with depression, a certain proportion will have evidence of increased peripheral markers of inflammation, usually acute phase proteins such as C-reactive protein, CRP, or various of the interleukins, particularly IL-1, IL-6. Some patients who have various medical conditions can be treated with cytokines like interferon. Patients like this have a high risk of developing depression. Perhaps a quarter to a third of patients will develop clinical depression when treated with these pro-inflammatory agents. And finally, there's tantalizing hints that certain anti-inflammatory drugs might be helpful in patients with depression. This is a study in which my group is engaged, called the Bidirectional study, funded by the Wellcome Trust and led by Ed Bullmore from Cambridge. And here we're looking at 200 depressed patients, 50 controls just there, and we're looking at CRP in the blood, corrected for BMI. Each dot represents an individual. As you can see, there's quite a spread. This is a log scale. But when you come to patients with depression who aren't doing well with conventional monoamine treatments, you start to see increases in CRP in a proportion of them. So perhaps about a quarter of patients with what's called treatment-resistant depression have evidence of elevated peripheral markers of inflammation. You can also see some evidence of this in the brain. And so here's binding to brain microglia measured by TSPO, and we have a group of healthy controls, so the open circles or triangles or depressed patients. And what you see is increased TSPO binding in various brain regions in the depressed patients. And this is normally taken as evidence of activation of the brain's immune cells, the microglia. So evidence here of both central inflammation in depression and also peripheral. So with that in mind, you might wonder whether anti-inflammatory agents might be helpful, particularly in treatment-resistant patients who are the ones most likely to show these raised inflammatory markers. And this is a study with a drug called infliximab, licensed for treatment of rheumatoid arthritis. It's a TNF-alpha blocker. And these are patients who failed to respond to usual antidepressant drugs, and they've been randomized to either infliximab, which is the dark circles, or to placebo, the open squares. And we're looking at decreases over time in a standard rating scale for depression. And this looks like one of my studies. There's absolutely no difference between the two groups. But, and a caution here, this was a retrospective split. If you break the patients down according to their baseline CRP, you do start to see an infliximab effect. So there are 60 patients overall, and there's no difference between the effect of placebo and infliximab. But as the baseline CRP starts to go up, so the more highly inflamed patients, there is a benefit of infliximab treatment. And this is intriguing because there's a lot of heterogeneity in the response to antidepressant treatment in depressed patients. And this suggests that pre-treatment stratification on the base of peripheral inflammation might help us predict what treatments to give to specific patients. Just to conclude, I wanted to mention another possible target. So this is from the BioDepth study again. If you look at the middle panel, we're looking at something called the P2X7 receptor. So that's a purinergic receptor found on immune tissue, both in the brain and in the periphery. And it's rather the same pattern that we saw with CRP. So this is gene expression of P2X7 on circulating mononuclear cells in depressed patients and controls. Here are the controls in green. The responsive patients, the ones who've done well with antidepressants, don't have any increase in P2X expression. But actually, patients who are treatment resistant, again there in red, show evidence of increased P2X7 receptor expression. So just a word about the P2X7 receptor. As I said, it's a purinergic receptor activated by ATP, which causes influx of calcium and leads to increased release of various inflammatory mediators. So just a few points about it here. As I said, it's a purinergic receptor activated by ATP under conditions of stress. It's present in both the central and peripheral nervous system, and in fact in all immune cells generally. It's normally silent, so it takes a lot of ATP to activate the P2X receptor, but under conditions of stress, it will be activated. And if you activate the P2X7 receptor, you get increases in various key inflammatory mediators, particularly IL-1, IL-6, and TNF-alpha. There is a central ligand. There are PET ligands for the P2X receptor, both in animals and in humans. Here I'm just showing a C11 GSK ligand, and this is work in mice whose immune system has been activated by treatment with LPS, lipopolysaccharide. I don't think it's come through very clearly, but there's an activation of P2X binding here, which you can block with cold ligand, probably shown a little bit more clearly here in various brain regions. And so binding a P2X is probably another way of assessing brain immune status. And because P2X is present throughout the body, it's quite likely, if one was measuring this with whole body PET, you would say activation of P2X in various peripheral sites too. So just to conclude, depression, I think it's now clear, is both a brain and a body disorder, and there's evidence of both central and peripheral inflammation. Peripheral inflammation might account for much of the comorbidity of depression, in particular cardiovascular disease, which is common in depressed patients and leads to significant loss of life in terms of years lived, and could also be a target for treatment. Total body PET imaging, I think, would allow detailed assessment of both peripheral and central aspects of inflammation, as well as the effects of anti-inflammatory treatments. Thanks very much.